Hello, everybody, and welcome to this evening's Discover Pathology lecture series. Thank you very much for joining us and spending some of your evening with us talking about infectious diseases this evening with Dr. Natasha Ratnaraja. I'd like to thank the Royal College team for helping to support this event, and in particular Joe Gillen, Jessie Junaja Walker, Joe Brinklow and Anghara Davies, in addition to Natasha Lawrence. Before we start, I'd just like to remind everyone that this is a series of talks, and that the next meeting will not happen in December because of the Christmas holidays, but we will have an interesting presentation from Dr. Jonathan Kell, who's a haematologist, and that will take place on January the 31st. Before we move on to the presentation this evening, I'd just like to make you aware of the medical electives scheme that's been supported by the Royal College of Pathologists. And I'll just put that on the screen there for you now. This is just to let you know that you can apply for a small grant to help support your elective up to the value of £1,000 if you're wishing to undertake an elective within one of the pathological disciplines. And that includes clinical biochemistry, haematology, immunology, veterinary pathology, infectious diseases, microbiology, virology, or cellular pathology. The deadline for that is at the beginning of February, so have a think about what you might want to do for your elective, and please do consider applying for a grant scheme for additional support. So this meeting, we have a particular format. There'll be a presentation. Put your questions into the Q&A for me to go through at the end. And in addition, during the presentation, there'll be a case discussion, so I'll help to navigate through those questions. Please feel free to put in as many questions as you like, and uprate the ones that you want to see asked, rather than asking the same question and again if you can see those questions. Please also check out the undergraduate curriculum, which is on the Royal College website under Discover Pathology, and the tab for undergraduate pathology and foundation doctors. You'll find there a curriculum structure for undergraduates with respect to all disciplines in pathology. So without further ado, I'd like to introduce Dr. Natasha Ratnaraja. Dr. Ratnaraja is a consultant medical microbiologist and infectious diseases consultant in Coventry and Warwickshire NHS Trust, and she's also chair of the Medical Microbiology SAC for the Royal College of Pathologists. She's dual accredited in both medical microbiology and virology, and it's my great pleasure to have her here with us this evening, and we're very grateful to have her expertise to be shared with us. So thank you very much, Natasha. Over to you.
Thank you, Alison, for the introduction. I'll just share my screen. Because this is just an introduction, what I'm going to do is give you a sort of broad overview about some of the things we need to think about when we're considering an infection in a patient, and what things we need to think about when we're prescribing as well. So I will go through the principles of diagnosing infection, touch briefly on the differences between bacteria and viruses, which may be especially important given that we're coming into winter, the importance of the gram stain, and just giving you an overview of commonly encountered organisms for different body sites and infections. And we'll go through a clinical case, which will lead us on to considerations when we're prescribing antibiotics and antimicrobials. So the first thing to think about, why do I love microbiology? Well, you have to be a detective. You are trying to, and it's the same for any pathology specialty, you're trying to work out what is going on, because often you can't see what is going on. It requires a lot of thought. You have to think, what is the likely source of infection? Whereabouts in the body, what organisms are causing it, how might they have acquired it? and what is the route of infection. So we're all aware of SARS-CoV-2. That's mainly the respiratory route, so we know that we need respiratory precautions to prevent onward transmission. So knowing the route of infection is really, really important. So what factors could affect the diagnosis and management? Well, travel history is always really important, especially now. We travel a lot around the world and quite easily compared to 2 centuries ago. And the travel history can, depending on the organisms, be as long ago as 6 months ago. So it's important to get a travel history within the last 6 months. Comorbidity. People are living longer nowadays because we're doing more. We've got more advances in medicine. And so people with organ dysfunction, such as renal failure, renal impairment, cardiac conditions, chronic lung disease, are living longer. But that means that some of the treatment we give to patients can predispose them to more severe infection or to opportunistic infections. Medications. So some medications may depress our immune system. So again, we're at higher risk of having more severe infection and opportunistic infections, but also when we're giving management and we're giving antimicrobials, we have to think about drug interactions, which can be really important. Colonization with organisms. We'll touch on this in a bit, but what organisms have we found in this patient previously, and have they had any treatment for that? So then aligned with that is looking at your previous microbiology and virology results and looking for known drug resistance. If this patient has a Staph aureus in their knee, are they known to have MRSA, or have they always had a sensitive staph or never had any treatment for anything? So if we look at the microorganisms that can cause infections, they're broadly split into bacteria, viruses, parasites, fungi, which are yeast and mold, mycobacteria and prions, and there are many more. But I'm going to focus just a little bit mainly on bacteria, but just talk to you about bacteria versus viruses. So bacteria are prokaryotes, the smallest, simplest, and they're ancient cells. They are single-celled organisms and microscopic, and they can be rods, spiral, or spherical in shape. And we'll talk about that in the gram stain. They're ubiquitous in nature and in humans. And it's important to recognise that all humans and most living organisms are actually covered in bacteria. And we're like our own ecosystem. We all have our own little flavour of bacteria that are generally quite friendly to us, but they are there. And it's what we do to ourselves in terms of giving antibiotics and in terms of disrupting our protection by the skin or operating, that we can upset that balance, that lovely balance of nature of organisms that are living quite happily in synergy with us. And these bacteria mainly reproduce by binary fission. They replicate their DNA, and they're usually susceptible to antimicrobial agents. I say usually because obviously we are seeing more antimicrobial resistance now. And in comparison, viruses are they're little molecules of genetic material which can be single or double-stranded DNA or RNA which have a protein coat. Some of them have an envelope, which is a layer of fat, and we see that with SARS-CoV-2. What is good about that, having an envelope, is that they can be easily killed by detergents and hand washing, which is why we all taught how to wash our hands to happy birthday. And viruses can also be different shapes and sizes. The difference is that viruses need to reproduce inside a living cell, such as humans. They can survive outside a host for a period of time, for example, on surfaces. But generally, if they need to survive, they need to be inside cells. As we know, antibiotics and antimicrobials are not effective against viruses. There are some antiviral agents that will work against specific viruses, but they're few and far between compared to the antibiotics, antimicrobials that work against bacteria. So coming on to bacteria, most bacteria will grow on the media that we use in the laboratory, on our agar plates or in culture broth. And there's been quite a few advances recently. about this. And one of the mainstays of the microbiology laboratory is the Gram stain. It was named after Hans Christian Gram, and it's one of the most important primary tests in the identification of bacteria. Even with all the advances in molecular diagnostics, we still do Gram stains, and they give us an awful lot of information while we're waiting for other tests to be done. And the Gram stain is based on the ability of the bacterial cell wall to retain crystal violet once you've decolorized it, you've given it solvent treatment. So gram-positive organisms have a higher peptidoglycan and lower lipid content than gram-negative bacteria. So they will take up a big stain and look purple. Gram-negative bacteria are they remain decolorized and they are a sort of paler pink, depending on the method that you use. So what we do is we stain the cell walls with crystal violet and we fix it with a crystal violet iodine complex. And then we decolorize it with acetone alcohol to dissolve that lipid layer and then counter stain it. And then we look at it under the microscope. This is great for the majority of bacteria, but not all organisms will stain well or at all with the Gram stain. So Haemophilus species don't stain very well. Mycoplasma doesn't have a cell wall, so you can imagine that the Gram stain doesn't work. And that's why sometimes you might see that there's evidence of an infection and something's growing, but we can't see it under the microscope. Spirochetes often need a different microscope to look at them, and mycobacteria need a different stain. And so we look at diagnosis for some of these more difficult to identify or even grow organisms using polymerase chain reaction, PCR, or serology, where we're looking for a detection of an antigen-antibody response, usually a 4-fold rise in titers, or we use these special stains. And it's too much to go into all of that now, and I think you don't really need to know too much at the level of a medical student. So if we look at the common bacteria, although Listeria is not that common. So if you can see my cursor, these are Staphylococcus aureus under the microscope, little cocci, little round spherical balls that are a deep purple. They're gram-positive and they're in clusters. So they're commonly known as bunches of grapes, although those don't look like bunches of grapes, but they are bunches of grapes. If you look at the streptococci, these are also gram-positive, a deep purple, but they're in chains and they're little spherical balls as well. So the cocci is obviously the round, and they're in balls. Then you have Listeria, which are gram-positive rods or bacilli. They are essentially just rod-shaped. They kind of look rectangular, but with rounded edges. And then coliforms, which are your E. coli's and your Klebsiellas, they are gram-negative and they are rod-shaped as well. Sorry, my thing is going too fast. Okay. So what are the organisms and why is it important to think about where the site of infection is? It's important to think about the site of infection because different organisms can cause infections in different sites. So when we think about our central nervous system and in the community, in adults, we think of meningococcus, because even now, even though we're mainly vaccinated, there are other strains that we don't have the vaccine for, or that's not commonly used. So meningococcus is still prevalent within our community, and roughly at about this time of the year when people start gathering close together. We can see meningococcus in knees, and it's a throat organism, but generally if you think about central nervous system infections that are acquired in the community, it's meningococcus and pneumococcus, and pneumococcus can cause pneumonia as well. And Listeria can cause food poisoning, but it can also cause a central nervous system infection. Some of the brain abscesses are flora that comes from the mouth, so the Streptococcus milleri, anaerobes, and also in terms of viruses, the enteroviruses and the herpes simplex virus can cause encephalitis and meningitis. In children, there are other organisms because children, especially neonates and babies haven't been vaccinated, and gram-negative organisms like E. coli and Haemophilus influenza, so group B, and group B streptococcus and HSV in older children can cause central nervous system infections. Central nervous system infections that are after you've had neurosurgery will be things that are associated with having to breach the skin barrier, so staphylococci and streptococci, but also because if you've got prosthetic material in, you get more of the gram-negative organisms and the enterococci and multi-drug resistant organisms because you have been given them antibiotics. Always think about your patient. Are they immunocompromised? Because then they are at risk for other infections, opportunistic infections, and also do not forget TB. We still have TB in this country, and we obviously have TB in other countries. It can be imported, but it can also be acquired in the UK. And it can cause central nervous system infections. So in the community, in the respiratory infections, again, at this time of the year, it's becoming more common, pneumococcus, Haemophilus influenza, viruses, and chlamydia pneumoniae and mycoplasma and Legionella, which are known as the atypical pneumonias, because they're the ones that might need a different antibiotic because either they don't have a cell wall or they're intracellular organisms. But when you come into hospital or you're in a residential facility, gram-negatives and multi-drug resistant organisms become increasingly important because of the contact with healthcare and the antimicrobial prescribing that patients may get. And again, opportunistic organisms in the immunosuppressed and immunocompromised. In the community, in the urine, we might see E. coli, Klebsiella, are the commonest causes of UTI, but also Proteus, Enterobacter, and Staphylococcus and Enterococci. But again, if you're a patient who has had renal manipulation or urological manipulation or antimicrobials, you might have multi-drug resistant organisms. In wounds, because you're breaching the skin mainly or a viscous, it's Staphylococci and Streptococci, anaerobes, Enterococci or gram-negative organisms. And in the bowel, we have a whole different type of organisms. We have the Staphylococci and the E. coli, but we have the ones that are most commonly foodborne and food associated, like the Campylobacter, Salmonella, Shigella, and also Clostridium difficile. And travel history is very, very important when you've got somebody with diarrhea, because if you've been abroad, you're at risk of helminth and nematode infections, and it's important because they require different treatment. Also, previous antimicrobial treatment and recent surgery history is very important, especially when we're thinking of C. diff. And if you're thinking about bloodstream, it's most of the above, probably not C. diff, and more. And it's important because the different bacteria have different growth requirements. So something like a Haemophilus is very fastidious. It needs to have like what's called a chocolate agar, it's a treated blood, so that it gets extra nutrients. Whereas if you have an E. coli, it'll grow on pretty much anything. And we need to put up different plates. We couldn't put up a raft of plates just thinking, oh, you know, just so we can catch something. We wouldn't have space in our laboratory, so we try and tease it down. So if it's a query chest infection, we put certain plates up to capture those organisms that I've mentioned. If it was something below the belt, so an abdominal or pelvic infection, we put up different plates to try and optimize the yield from that specimen. And that's why it's important to think about what the source of infection is, as well as thinking about the antibiotics, which we'll come on to later. But growing something on a plate doesn't mean that it's causing infection. I've mentioned that our bodies are an ecosystem. We're covered with organisms. So we might just pick up something that we are colonized with. And it isn't always easy to differentiate between infection and colonization. Colonization often precedes infection. We see this with carriers of MRSA, but we don't know who is of those patients who are colonized with an organism, how many are going to go and develop infection and when they're going to develop that infection. It's important to remember that colonization with a multi-drug resistant organism is often long-term. So we don't want our patients to get into that state. We want to help them just have treatable organisms. And inflammatory markers are not always useful in differentiating between infection and colonization. Then there's contamination, which usually occurs at the time of sampling. Most commonly we see it in blood cultures, when we're taking blood cultures because we don't decontaminate the skin appropriately before we sample. And also post-sampling procedures, everyone has incidences of dropping samples onto the bed prior to putting a specimen pot. You've picked up the organisms that are lying on the bed then, so you're not necessarily picking up what organisms were in that sample. It's not very common, but it does happen. And the problem with contamination is it can lead to inappropriate antimicrobial prescribing, because you're treating for an organism that is not necessarily causing an infection, and then you could subsequently develop, you could acquire multi-drug resistant organisms or even C. diff infection, and we don't want our patients to come to harm. So at this point, I thought you might be quite full in terms of having a lot of information. So I'm going to go through a case, and if Alison's going to monitor the chat so that you can put some comments up, and just please do try and have a guess at the answers. It's not a difficult case. It's not case 3, it's case 1. Sorry, I forgot to change that. So we've got a 68-year-old man who is admitted with shortness of breath, prominent sputum, and a new onset of confusion. On examination, his blood pressure is 110/55. His pulse rate is 110 sinus rhythm. His respiratory rate is 32. His chest X-ray shows right lower zone consolidation. And his arterial blood gas shows a PO2 of 7.5 kilopascals, PCO2 7.2, and a bicarb of 32, and his urea is 8.5. So thinking about what the diagnosis is, so please put in the chat what you think the diagnosis is and what would you prescribe and why. So we'll give you just a minute or so. I'm not sure if I can see the chat.
I've got the question and answer tab open. We've not got any contributions just yet, but hopefully we'll get them in just a moment, because it always takes a few minutes just for people to type and to have a little think about what they think is going on. Oh, here we go. We've got some coming through. An anonymous attendee has suggested that we would prescribe amoxicillin, and a further participant has suggested a diagnosis of pneumonia. Very
good to those two anonymous people, because that's right, it is a community-acquired pneumonia, and amoxicillin is a good choice of antimicrobials. For some reason I can't move on, I don't know why. So one of the things we look at is the CURB score, and I don't know if you're familiar with that yet, depends what level of training you're at. So the CURB 65 is a mortality prediction tool for patients with community-acquired pneumonia. And these are the criteria. You've got to be 65 or older, and our patient is 68. Confusion, which I didn't mention, and the urea has got to be greater than 20. And respiratory rate of greater or equal to 30 breaths per minute. His was 32. Blood pressure systolic less than 90, or diastolic less than or equal to 60. And you score 1 for each one that is present. And you calculate the CURB 64. And I would encourage you to do this for anybody that comes in with community-acquired pneumonia who is 65 or older, because this shows what the 30-day mortality is. So if you've got a score 0 or 1, you've got a very low 30-day mortality, and you can often treat this patient as an outpatient. If your score is 2, the mortality goes up to 9.2%, and you would treat them as an inpatient, not necessarily with intravenous antibiotics, but they might require supplementary oxygen. And if it's 3 or more, you might be considering intensive care treatment, because the mortality goes up to as much as 40%. Of course, you're always going to look at the news too, because that gives you the individual requirements that the patient has, what level of oxygen they need, if they need any, and also always consider sepsis. So his COPE score was 4, and at our trust, he's treated for severe CAP, community-acquired pneumonia, with co-amoxiclav. I think amoxicillin is just as good, and I like amoxicillin because it's mainly oral flora, your streptococci, and we don't have a lot of penicillin-resistant pneumococci in this country. If it travelled abroad, we would think differently. And the clarithromycin. And if he requires an admission to intensive care or is critically ill, then you would liaise with us, because with the critically ill patients, we might have a lower threshold for changing antimicrobials and escalating them. But this is a perfectly good regime, as is amoxicillin and clarithromycin. As I said, what we're covering the Streptococcus pneumoniae, the Staphylococcus aureus, and atypical pathogens. So the clarithromycin works for intracellular organisms and organisms without a cell wall, like the mycoplasma, which is why we add that as well for community-acquired pneumonia. We screen those. Not all trusts do that, not all hospitals do that, but we screen using Legionella urinary antigen. And if the atypical pathogen screen is negative, then we would stop the clarithromycin. And that is obviously for somebody that's not penicillin allergic. But what organisms are not covered by this regime? So MRSA is not covered by this, and multi-drug resistance is not covered by this, and Pseudomonas is not covered by this. And that's where it's important to look at your previous microbiology results. Have they been in hospital? Because if this is just for community, if it was hospital-acquired pneumonia, we would want to cover for things like Pseudomonas and other things. So that's why the previous microbiology is very, very important. So antimicrobial prescribing is not as easy as people might think. You can't just simply know what antimicrobial to use. So the common classes of antibiotics are beta-lactam drugs, and these are the ones that are really the workhorses of the infection department. They're your penicillins, which is generally amoxicillin, benzyl penicillin, co-amoxiclav, and you could include the carbapenems in there if you like. So the meropenem that we escalate to, some people would use imipenem, doripenem. And your cephalosporins, your cefuroxime, your cefotaxime, and your ceftriaxone. And there are fluoroquinolones, ciprofloxacin, levofloxacin, aminoglycosides, which are the gentamicin. It was the one that you most commonly use. Some of you may be familiar with amikacin. And the glycopeptides are your vancomycin. And you will see those commonly prescribed on antimicrobial charts. Macrolides are erythromycin and clarithromycin, used for atypical infections and often used in pregnancy, the erythromycin, because it's safe to use in pregnancy. And your tetracyclines, generally people use doxycycline to cover Haemophilus influenzae in patients with COPD. Your sulfonamides are trimethoprim and Septrim, which is cotrimoxazole. And those are drugs that are really ancient drugs, but actually have a really good activity. But they have drug interactions. We have to be careful with those. And they're called de novo drugs. They're not really de novo anymore because they've been here for ages, but linezolid and your daptomycin and your tigecycline. So those are the brief common classes of antibiotics. And I'm not going to go through this because it's quite big. But generally, this is something as a take-home guide that you can see. If you've got a gram-positive bacteria, such as the Staph aureus or your beta-hemolytic streptococci, these are the antibiotics that can work. And if you look at this is why it's useful to think about what kind of organisms could be causing these infections, because if you think that somebody's got a gram-positive infection, I mean, you wouldn't be able to prescribe these anyway without microbiology approval. But daptomycin and linezolid do not have any gram-negative activity. So what people think are a stronger drug, it isn't necessarily a stronger drug. It might have a smaller spectrum of activity. If you look at amoxicillin, it can still cover some gram-negatives, and co-amoxiclav can. And these are cheap as chips drugs that work really well because they're beta-lactam drugs. And when you look at the quinolones, with the exception of maybe levofloxacin, them tend to be more of the gram-negatives. So you've got to think about where they work. Oops. For some reason I can't go on to the next slide, but let's go. And this is from more of the organism. So I just thought I'd put this in so that you've got this to look at. And these are your fecal streptococci and your Pseudomonas. And the trouble with Pseudomonas is there's only one oral agent that it's susceptible to, and that's the quinolones. Everything else is either intravenous or given via oh, I've forgotten what to say. Inhaled. I'm going to say it's inhaled. But so we want to preserve those because Pseudomonas can become resistant to antibiotics very quickly. So why is antimicrobial prescribing so important? Well, it's patient safety. There are lots of government targets about reducing MRSA bloodstream infections, and there's lots of other things to worry about. But the main thing for me is that we want to give the patient the right antibiotic. If we can give an antimicrobial that works and is what considered first line, that makes the patient get better sooner. Now, I mentioned that beta-lactam drugs, the penicillins, are a workhorse of infection prescribing, but people say that they're allergic to penicillin, and they're not actually allergic because we don't take a proper history. And it's important to follow your hospital or trust guidelines to look at penicillin allergy. Are these patients actually allergic to penicillin? Because usually having a upset stomach, it does not mean that you've got penicillin allergy and you can prescribe that, because as you've seen from those charts, the second line drugs, like maybe giving a quinolone or something, may not have as broad a spectrum and may not be as appropriate. And it's best practice for patients. We should always undertake to give the best practice for patients. And this is important, the cost of drugs. If we prescribe something with a generic name, so for those of you who've heard of Tazocin, don't write Tazocin on drug chart, because Tazocin is now what's called off-label. So actually, if you prescribe piperacillin tazobactam, you are saving the hospital that you work a lot of money, because the piperacillin tazobactam, that's the generic name, is often much cheaper than a brand name. And that's the same for all antimicrobials, not just Tazocin, piperacillin tazobactam. Anything that's off-label can be often cheaper. And if you have adverse events, if you have a multi-drug resistant organism that's hard to treat because you have less antimicrobials that you can use, or if you have C. diff, then you have an increased length of stay. Patients are in hospital for longer, and nobody wants to be in hospital for longer than they need to be. And the longer we keep patients in hospital unnecessarily, the higher the risks they are for developing other hospital-acquired infections. So it's not good for our patients. So who's responsible for ensuring that the correct antimicrobial is prescribed in the correct dosage for each patient? It's you, and it's everybody. So it's not just us who prescribe them. It's the nurses that administer the doses. It's the ward pharmacists. It's everybody that comes into contact with that patient. So it's all of us. But if you are prescribing an antimicrobial, you should be checking that everything is correct. And these are the considerations, really. So you've got to think of the site and source that I discussed of infection. Have they had recent antibiotics, including prophylaxis? Because if we have had recent antibiotics, you've wiped out the nice, friendly bacteria that live in your nice little ecosystem, which means that the bugs that are resistant to that can predominate. And that's what happens with C. diff. Are they allergic, as I've just discussed? Any adverse effects? Some patients might not be able to tolerate nausea, and certain antimicrobials, ciprofloxacin, for example, at higher doses can be very nauseating and people can't tolerate them. Do they interact with other medications? That is very, very important, because you don't want harm to come to your patient. So some of our antimicrobials, such as rifampicin, will interact with warfarin. Ciprofloxacin will interact with loads of things. Trimethoprim and cotrimoxazole will interact with things. So you've got to look at all of those. And are there any contraindications? Have some of the pre-existing conditions, which is often because of the medication they're on, or pregnancy, because obviously we don't want to harm the developing fetus. And sometimes there may not be an option available and you have to do a risk-benefit analysis looking at that. Renal and liver function, how are your antimicrobials excreted? Are they excreted renally? Are they excreted hepatically? Have they got renal or liver impairment? And is that going to allow the drug to accumulate? So we have to take that into account. We may need to change the dose, or we may need to change the frequency that we give the drug. And it all depends on which antimicrobial prescribing. The susceptibility pattern and the colonization infection with no multi-drug resistant organisms is pretty much the same. So if you have an organism that's picked up on in the microbiology lab and it's resistant to amoxicillin, we're not going to prescribe amoxicillin, are we? So we're going to look at what the susceptibility pattern is and what we can use. And wherever we go, we try and initially we might need to go broad spectrum, and those are the antibiotics that can cover gram negatives and gram positives. But then once we know what the organism is, we could narrow down the spectrum. So for example, if you had something that was, you might start with coamoxiclav, but then if we see that it's sensitive to amoxicillin and there's no need to give that broader spectrum antimicrobial, we should narrow down to amoxicillin as soon as possible. You've got to think of the risk of C. diff. Probably almost 20 years ago now, there were high rates of C. diff in the UK, and people were dying. And there was one particular strain of C. diff that was associated with ciprofloxacin use, which is why ciprofloxacin isn't used first line as much now. And any antimicrobial can cause C. diff. Some are less likely to cause C. diff, which things like gentamicin. But most of the beta-lactams can cause C. diff. Anything can, and it can just be one dose sometimes. So you've got to think, does this patient really need treatment, and am I doing giving the best treatment? And warn your patients about the risk of C. diff, because they need to know. Formulation, can you give it orally or can you give it intravenously? And sometimes you have to think about the bioavailability. That is, so when you give an oral drug, how much of that active ingredient actually gets into the system, into the bloodstream and to the tissues and the organs, whereas intravenously, obviously 100% generally goes in. So you've got to think about that. Can you give it orally? So something like linezolid, intravenous and oral are both 100% bioavailability. So you can give oral and it's just as good. Do you need therapeutic drug monitoring, such as with gentamicin or vancomycin? Because if you need therapeutic drug monitoring, it's not so easy to give that in home. And your trust antimicrobial policies are very, very important, your hospital policies, because they are based around the resistance patterns for the patients that your hospital or your trust serves. So resistance patterns can vary just literally 3 miles down the road. So it's important to know what that policy is and follow those guidelines. Those guidelines are there for a reason. So when you move hospitals, you'll see different policies, and there's a reason for that. It's because we're looking at the antimicrobial resistance patterns. So when you're choosing your antimicrobial, think about what organism is likely to be causing the infection. Consider the possibility of multi-drug resistant organisms, and think of colonizing organisms, and think of any risk factors that the patient might have for acquisition of multi-drug resistance, and think of your local penetration and pharmacokinetics. So for example, daptomycin, this is the gram-positive only organism, very good for killing staphylococcus in the bloodstream, but will not work very well on the lung because it's inhibited by lung surfactant. So you wouldn't prescribe it for a chest infection. Tigecycline is highly plasma bound, so you goes into the tissues very well, so it's very good for organ infections, but for a bloodstream infection, it's not so good. And vancomycin also has poor tissue penetration, but vancomycin is a very good drug to give if you have allergies. So sometimes you may need to adjust the doses to look at that, or look at the way you're giving it. So using oral formulation, and we try and do what's called IV to oral switch. So sometimes patients need intravenous antibiotics initially to get that drug in and to get good therapeutic levels quickly. But once they're stable, we can change them to orals, to tablets, because that reduces the risk of a cannula-associated infection. And it means they can be discharged home much faster because they don't need to have any therapeutic drug monitoring. And psychologically, it's much better for the patient not to be tied up to a drip. Think of your renal dosing, especially with the aminoglycosides. Look at your GFR, your creatinine clearance, and there are lots of calculators out there that you can find online that will calculate the creatinine clearance or the GFR for you. Many hospitals have systems that will calculate that for you as well. It's a more accurate assessment of your renal function than the creatinine. Think of your elderly patients. They can accumulate drugs within them and they have a lower muscle mass, so they will have a reduced GFR. So that doesn't mean they haven't got renal impairment. It's just that they've got a lower muscle mass, so they might have renal impairment with a GFR that looks a bit higher than usual, but it's reduced. And they're at higher risk of toxicity with beta-lactam drugs, so you may need to give less of a beta-lactam than you would give to somebody who is a bit younger. And you need to regularly monitor your renal function or your hepatic function, depending on how the drug is excreted. Common side effects are anaphylaxis and allergic, as I've said. Gastrointestinal upset's not an allergic reaction. Rash, and with the aminoglycosides is the ototoxicity and nephrotoxicity, which can also be seen with the glycopeptides, so that's vancomycin. The sulfonamides, so this is the trimethoprim and the cotrimoxazole, they can cause granulocytopenias. Quinolones can cause tendinitis, and staining of teeth and bones is seen in the tetracyclines, which is why we tend not to give it to children. It does happen, we do give tetracyclines to children, many doxycycline as well if we have to, but it's after a risk-benefit analysis. And you can get a photosensitivity rash if you're on doxycycline, which is a bit of a trouble because doxycycline is often used for malaria prophylaxis, and that's because you're going to a hot country. So, as I said, our antimicrobial policies are evidence-based and they're based on the local resistance patterns and best practice. And our aim to do this is to reduce unnecessary prescribing with a subsequent reduction in antimicrobial resistance, hospital-acquired infections, and C. diff. So, in summary, if we are prudent with our antimicrobial prescribing, this is key to preventing those adverse effects associated with antibiotics. We shouldn't be harming our patients. And you have to think of so many factors before you start any patient on antibiotics. And if in doubt, you always ask the microbiologist, the infection specialist, the ward pharmacist. They're all available to help you. You've got to tailor your therapy to the individual, but you follow the trust antibiotic guidelines wherever possible. When you have to deviate, that's usually a complicated patient, and that's usually when you would be seeking the advice of your infection specialist. Thank you.
Thank you very much, Natasha. That was a really fantastic introduction to the complexities of infectious diseases and prescribing. I certainly have learnt a lot, some things that I never knew, but also a reminder of many of the things I've forgotten while I've been a cellular pathologist for the last 20 years. So thank you for that, because it's been a great refresher. In particular, I was really taken by what you said about making sure that the information is full on the request form, so that you can select the right kind of agar plates to culture the organisms of interest, because that's something that's true of all request forms, I think. But I didn't realise it had a bearing on the choice of plates that you bring out, and also that those nuances about taking specimens and how that can help with deciding whether it's a colonization problem or a contamination versus a true infection. So that was really, really useful from my point of view.
Thank you.
I'm hoping that people will post some questions on the Q&A as using the same function that you did before for the case. And I'd just like to thank everyone for participating in the case. I thought that was really instructive. It's really lovely to get people thinking about the case, and that was a really great example. So we've got our first question that's come through from Abigail James. And she's asking, is there a way to differentiate between viral and bacterial infections without investigations when it comes to a fever? Is it viral or bacterial?
So there are some rough rules, but they are, as we know, rules are always meant to be broken. So generally, when we look at, looking at temperatures, viral temperatures tend not to be as high, but that all goes out the window with flu. So you can't really. When we look at CSF, sometimes for the purposes of exams, you always have to look at the differential and the white cell count. But in practice, it's not always that helpful. But when you look at a white cell count in, say, a viral encephalitis or a viral meningitis, the raised white cell count is usually in the hundreds. Whereas if you had a meningococcal infection pre-treatment, this is before any antimicrobials are prescribed, then they used to be much higher, towards the thousands, and that also can guide you. But because everybody has antibiotics before they have a lumbar puncture, that's gone out the window now, I'm afraid. So realistically, that's where you look at, excuse me, you look at the source of infection. So if someone has diarrhea, say, for example, we're coming into winter, so I'm thinking of winter pathogens. If someone has diarrhea, we would have a little algorithm. So we would always culture for the common pathogens like Shigella, Salmonella, Campylobacter, and the E. coli 0157. And we always do everything for C. diff, that's national guidance. But where it comes to a virus, we wouldn't do that unless we were considering an outbreak. So if you had two people in the same bay that had diarrhea, we would consider testing for norovirus as well, or other fecal pathogens. And it would be the same if you had two people with respiratory virus, with a respiratory infection who aren't producing pollent sputum, but they've got a dry cough. We might think, is that viral? And that's so that's where you have to be the detective. You have to have things crossed off, but I'm afraid there was no easy answer.
I mean, that sounds very similar to a lot of the answers that I give, that it's often more complex, and you take many pieces of the puzzle and put it all together, and take an educated decision about what you've got before you. But I mean, I think that's a great question from the medical student involved. It shows quite a lot of insight, so thank you for that.
Yes.
Kate, we've had a request that you gave a sneaky indication that there may have been case scenarios 1 and 2 somewhere, and somebody's asked if they could have them.
Yes, you can. I've actually had 4, but it was because of the times. So you can definitely have, I can definitely send Alison or Joe or Jessie the cases. Usually they're interactive, but I can send you those cases. That's not a problem.
Well, if you do that, that would be really helpful. And along with this recording, I can ask that we have those attached to it so that they're there to view if you're happy with that.
Yeah.
Super, thank you. Victoria Cape has asked, how did you get into this role, and what is the training pathway in pathology like?
In pathology, or is infection? So I've got quite convoluted, unfortunately. So I trained in Manchester, and a long time ago, and I got interested in working. I worked in the infectious diseases unit as a 5th year medical student at North Manchester General, there's only Manchester students, and it had just moved there. And I am old enough to remember HIV in the early days, so we did lots of HIV. It really interested me, and I was always a physician primarily. And then after my house jobs, we didn't do F1, F2, we just did F1 then. I think you might have done, Alison, as well.
That's right.
So 4 days after my house job, we went to New Zealand for a year and stayed for 8. And I did my medical training. I did my medical exams there, and I did my physician's exams. And I got really into infectious diseases there, already having a pre-interest, because the pathology is great in New Zealand because you have the Pacific Islanders. So you see rheumatic heart disease, you see TB, you see lots of things. And then I wanted to do microbiology because to me, you can't do one without the other. And that's actually what's been recognised here, as well as in Australasia. So now the infection training here is that after you've done your F1 and F2 years, you have to do IMT, internal medicine training, and you have to have your MRCP. And Anne-Harriet will correct me if I'm wrong on this, because I'm trying to remember. And you do that, and then you apply for infection training, which is going to probably change again, but you do 2 years of combined infection training, and then you can do your higher specialist training, which would be either focusing on infectious diseases and microbiology, or infectious diseases and general internal medicine, or infectious diseases and virology. There's very few single specialty medical microbiology now, or medical virology, but there are still some around the country. But I'm happy if you're interested, please let us know.
And are you all patient facing? So you all do ward rounds and see patients on the wards?
I do, because I'm dual accredited, and we are moving to that. And Harrod and I are doing a fair bit of work on this, actually trying to get us to be more patient facing. And actually the medical microbiologist we do intensive care ward rounds every day. We're involved in a lot of MDTs, and it depends where you work. So I do a lot of work with the intensive care units and the cardiothoracic critical care units, and I do a lot of women and child health. So I spent a lot of time on the neonatal unit, so you can have an interest in things. We also have clinics for outpatient antibiotics, and we work in a department of infection with infectious diseases and infection control. So I like to keep, it's very varied. I like that. So you know,
certainly getting that sense of variety there, and I mean that must be something that really keeps the interest up over many years of a career, and that's a real asset for your specialty, I think. That's fabulous. Thanks for that oversight. Well, I've had another question from Abigail James. Would we still prescribe an antibiotic to a patient with a viral pneumonia, but where the cause is unknown? So would you give a trial, I think is what is being suggested, is that if you can't differentiate between a viral fever and a bacterial fever, would that be reasonable?
Yeah, that's another good question for Abigail. They're all good questions. Yes, so quite commonly in winter, you can't tell. And often the yield from sputum is quite low because people do tend to spit more than give what I would call a good hoik. You know, a big chunky specimen. We like big chunky specimens in the lab.
We do.
We do. The more the better. But quite often you'll see, because if they're unwell, you can't play Russian roulette. You have to say, we will cover them for bacterial pneumonia, and you can have coexistent infections. You can have a viral with a secondary bacterial infection. So often we do, and that's the first thing we do. If they're found to have, say, influenza or SARS-CoV-2, we would look at them and look at their chest x-ray, look at any CTs or anything, and look at the whole patient and think, well, actually, is this just viral, or is this viral with a secondary bacterial infection? So yes, we would absolutely do that. But the key is there's a national initiative called Start Smart Then Focus. And so you start smart, you give that antimicrobial, but then you review. And the important part of any infection specialist or any prescriber is to review your antibiotics, usually after 48 hours, because you have the microbiology back, you have the virology back, and then see, can you then narrow your spectrum of antibiotics if they need them, or can you get rid of things, or can you change from intravenous to oral formulation?
And does that apply to those in the community as well? Would general practitioners usually get the virology test done as part of investigating their patients, or would that be if somebody isn't resolving?
So virology in the community can be difficult because you've got to get all the swabs and you've got to get them done. So some places might do that. Generally, we don't do it outside of pandemics or because it's just too difficult to do that. So people have said that, oh, I had the flu, but they haven't been diagnosed. Generally, in a pandemic, you'd get diagnosed, but it's, you know, that everyone had to go and have their COVID swabs at some drive-in centre.
Yeah.
So you know that GPs don't normally do it, because also they can't have lots of people with a potentially highly communicable disease in their GP surgery, because that would cause havoc, really.
Absolutely. Yeah, no, that's really a really good point. And we just had one last question. Somebody was asking about tropical medicine and how that fits in with the training program. Is that something that's covered in general training, or would you need to do some specialist training? I understand there's a centre in Liverpool and there's one in London.
And there's one in Birmingham, yeah.
And there's one in Birmingham. Okay,
yeah.
I didn't know that. Thank you.
So there's so there are tropical medicine. It has come off the curriculum. However, most places, I mean, obviously I'm in the West Midlands, and we have the Department of Tropical Medicine at Heartlands, and we have a travel clinic. So we do some travel clinic medicine as well. So you are encouraged to do that. And during your training, you can have what's called an OOP, out of program. So you can go abroad and get some experience there. So there are plenty of opportunities to get your tropical medicine training and experience. And sometimes there are some hospitals, like I used to work in inner city Birmingham, where tropical medicine comes to you. You don't have to go there.
Yeah.
So sometimes in a DGH you can see tropical medicine, malaria, because of globalization. So you will get some, but yes, it has come off the curriculum, but we still have it as an important part of training, and it's something that's been looked at nationally at the moment. So it
sounds like there's some really fantastic opportunities out there to carve out a career in different areas of interest within the specialty itself. I mean, it sounds fantastic. So one last question then, just before we go, because we're just over time, but I do like to answer everybody's questions, if you don't mind. Victoria Capes asked another question about patients ventilated and get VAP. Is that
ventilator-associated pneumonia?
Okay,
yes.
Thank you. Thank you. Victoria obviously knows more about this than I do. Are antibiotics a useful treatment in those patients who are ventilated?
Yes, and it's another thing that's we don't really understand when we're trying to measure that. So for those of you who don't understand, ventilator-associated pneumonia is a bit different from hospital-associated pneumonia. These are patients that are intubated. So there's a lot of humidified air, and there's fluids going down. So you've got a nice warm, and because you're being ventilated, you've got a nice warm and moist environment in your lungs. So you can get all the pseudomonases and the organisms that can literally line your respiratory tract. So antibiotics are key. Viruses won't work against, it's usually not viruses for ventilator-associated pneumonia. So we would treat with antimicrobials, and that's why it's important to distinguish between ventilator-associated pneumonia, community-acquired pneumonia, and hospital-acquired pneumonia.
Super.
And it's not that easy.
No, none of these things are, but that's what makes our job so interesting, isn't it? Absolutely. If it was straightforward, it would be boring. And that's why we need experts such as yourself. And you know, I for one, and I'm sure the medical students who've tuned in this evening will join me in thanking you for giving up your valuable time to help educate us all. And share your experiences, particularly, you know, with the career pathways and the opportunities out there. I'm sure you'll have inspired some people along the way. So thank you so much.
Thank you.
It was a pleasure to meet you. And I look forward to seeing everybody again in January. So do have a lovely Christmas in the meantime. And I'm sure the Wales-England match is still going on for those of you who wanted to catch the end. Come on the Cymru. So we'll end it there, and I wish you all the best. Thanks again.
Thank you, everyone.